Hamatakia pe pate dutuanamakia chante washte na pe che yuzape. Thank you for having me today. I'm speaking to you from Treaty 1 territory on the homeland of the Métis Nation, and I'm really happy to be with you today to talk a bit about reconciliation in public health. Of course, recognizing that this is a long and complex topic, but it is always important to start somewhere. I'm just advancing to the second slide now for people who are following along. So the slide titled Public Health. This is my favorite definition of public health, the one from Institute of Medicine in 1988. What it says is what we as a society do collectively to ensure the conditions in which people can be healthy. So when we consider the health gaps that First Nations, Métis and Inuit people experience compared to the settler population of Canada, we also have to understand that it was what we as a society did collectively that created the conditions that created those gaps. And of course, this is reflected in call to action number 18, which is the first of the health-specific calls to action in the Truth and Reconciliation Commission of Canada, in that it calls on us to understand the current health status of Indigenous people as being rooted in government policy. I have not done a background of the TRC today because I have decided to assume that you would have at least some familiarity with what it is and why it was established. So I'm just going to go ahead and go forward from there. But if you need more background on that, of course, you can look at the TRC website and all of this series of reports. So advancing to slide number 3, which says Web of Being, Social Determinants in Aboriginal People's Health. I think that when we're talking about Indigenous health, it's really important that we use Indigenous conceptualizations of Indigenous health. And a few things that are different about these Indigenous conceptualizations of health as captured in this particular diagram of determinants of health. First of all, they do include some Indigenous specific historic experiences, like experiences of residential school, dislocation, both from land and community and culture, as well as explicitly including contemporary factors that influence the health of Indigenous peoples, like racism, and really multiple levels of racism. So when we're thinking about policies that impact on Indigenous people's health, we really have to think both about the ideology that leads to certain policies being created and then implemented by different governments, as well as the actual impact of the policies themselves. So this is one that I would just keep in mind. Without a doubt, you will see determinants of health in here that are within the mandate of your particular NCC. So moving on to slide 4, which is entitled Principles of Reconciliation. One of the documents that the TRC did result in was a document called the Principles of Reconciliation. There are 10, and I'm only going to discuss one today. And it is, in fact, the first principle of reconciliation, which says that the United Nations Declaration on the Rights of Indigenous People is the framework for reconciliation at all levels and across all sectors of Canadian society. And the first thing that I would say about that one is it says at all levels and across all sectors. It's telling us specifically that wherever we work, and whatever we do, we have a responsibility to understand what UNDRIP is and how it applies in our contexts. This is not just about the federal government's relationship to the national Indigenous organizations, for example, but each of us in the work that we do have a responsibility to use UNDRIP to guide our relationships with Indigenous people and the work that we do that impacts on our communities. So UNDRIP, just for a little bit of background, took approximately 20 years to develop and negotiate at the United Nations level. There were many people from Canada who were involved in those negotiations. It was ultimately passed at the UN in 2007. Canada was one of 4 countries at the time that voted no, along with the US, Australia, and New Zealand. And then only within the past year has our government committed to full implementation of UNDRIP. As I mentioned, there are 9 other principles of reconciliation, which are not any less important than this one, but we certainly can spend a lot of time just talking about UNDRIP, and that's why I've decided to focus there today. So UNDRIP includes 4 key themes, and I'm going to walk through these each and provide both a definition and an example of how they might apply to public health. So now I'm looking at slide 5, which has those 4 key themes. And broadly speaking, they're the right to self-determination, the right to cultural identity, the right to free, prior, and informed consent, and the right to be free from discrimination. A couple of notes just about these 4 key themes to help inform us. One is that UNDRIP applies specifically both to individuals and to collectives of Indigenous peoples. And so, we're going to talk about self-determination first, but it's both the need to respect that individually and to find processes that Indigenous people as collectives themselves can provide that type of collective vision and consent. The other thing that I would just say is these are not mutually exclusive themes. They are highly interdependent, and so there is some overlapping in the concepts. So moving on to first talk about the right to self-determination. I think that there's lots of very complicated definitions. Sometimes the way that it's described, which I think is a fairly simple one to understand, is that Indigenous peoples have the right to decide what is best for them and their communities. Sometimes we think that this is something that's nice to do, for example, in health equity work or patient engagement, community engagement. We consider it like it's nice to do if we can do it, but we don't actually often consider it as a right to do or what our obligations in that regard are. Further around this right of self-determination in terms of how we understand it, specifically one of the things that it means is that Indigenous people have the right to be both full citizens of Canada as well as members of their Indigenous communities. In healthcare specifically, or relationship to the healthcare system, including public health, Indigenous people have the right to use the Western healthcare system as well as any Indigenous knowledge of health and healing as they determine best for themselves. Now, I think if we are going to have some moments of honest reflection around public health and Indigenous peoples, we would understand and have to kind of come to grips or reckon with the fact that Indigenous peoples have often been excluded from meaningful participation in priority setting, collecting, analyzing, or contextualizing data specific to Indigenous peoples where it exists, have often been excluded from program planning, implementation of programs, or other really critical roles to the work of public health. And this has happened for a couple of different reasons. One is through structural barriers that have served to prevent Indigenous peoples from participation in the public health workforce. So, for example, I'm a medical officer of health, so I've been through medical school and residencies and that whole thing. And a lot of those structural barriers to gaining admission to medical schools have been previously well defined, including things like chronic underfunding of First Nations education, which is a key factor in dropout rates, as well as in students who do complete high school being adequately prepared to enter into university in science-based programs, for one example, as well as things like the use of the medical college admissions test as a core kind of determinant in a lot of medical school admissions processes, which is known to be racially biased. So that's, just one example of how structural factors act as barriers to participation in the public health workforce. We could also look at things like union roles as it might impact public health nurses, for example, and times when you might want to hire an Indigenous public health nurse for a specific role, but because of the union rules, you have to offer the position to someone who is more senior. So those are some of the structures that we can work on to start addressing the participation of Indigenous people in the public health workforce as one way to exercise the right of Indigenous people to self-determination in public health. The other mechanism that I would just reflect on is really the lack of governance structures or opportunities for meaningful participation or engagement of Indigenous communities that create space to have this right honored and respected and fulfilled. So one of the consequences for this is that for the most part, only Western knowledge of health and healing has been included in the work of public health. Sometimes this is called epistemic racism, or type of racism that has to do with valuing one set of knowledge over other forms of knowledge, in this case, Indigenous knowledge, and really not seeing it as having value to the health of Indigenous peoples. So when we think about how we might act differently in the future to respect the right of self-determination, we will need to think about active strategies to remove barriers and creating meaningful work for Indigenous people in public health, with opportunities for advancement throughout the public health system, and also really the need to negotiate and co-create governance structures that respect the right of Indigenous people to inform and determine which public health programs and services would best respect them. And then lastly, although not least important, enacting the humility and respect that's needed to learn from Indigenous knowledge keepers around how to promote the health and healing of Indigenous peoples. So I'm going to move to the next slide, which is slide 7, and talks about the right to cultural identity. So this right reiterates that Indigenous peoples are equal and also have the right to be different and identify with their Indigenous community's culture. This does not have to mean a specific reserve at all, but rather can encompass a diversity of Indigenous communities that currently exist, whether urban or more rural or remote community-based, and often can be in the form of large kinship networks or other social factors that one finds connection and finds their kin through. This image that I have on this slide was developed by Karina Walters and her colleagues, and it's called the Indigenous Stress Coping Model. And what I would use it to highlight is how Indigenous culture and connection to the cultural identity is really a core determinant of health for Indigenous peoples. I've done a fair bit of international Indigenous health work, and I've actually never encountered a more traditional Indigenous conceptualization of health that did not include some concept of culture as being key to Indigenous health. So what this figure is showing is that if we consider the range of stressors that an individual Indigenous person or Indigenous community experiences, which can include historic trauma, racism or microaggressions, family violence, multiple losses, poverty, food insecurity, housing inadequacy, lack of employment opportunity, etc., those can be buffered or mitigated by the range of coping mechanisms that is available to that individual family or community. And so a lot of the buffers that they've described do link towards cultural identity and the connections that are needed to carry a culture. So links to family, utilization of traditional health and healing practices, being involved in community, having that strong identity, practice of spirituality, etc. And that depending on the balance of those stressors and coping factors, that we have these range of health outcomes. Now, in the 2008 apology, then Prime Minister Stephen Harper did explicitly explain that the goal of residential schools was to kill the Indian in the child, and specifically by disrupting access to this range of coping or buffering factors. So from disrupting kinship ties, removing ability to speak language or hear the language spoken. Of course, at the time, the Indian Act was also making a lot of those traditional healing practices, such as ceremonies and potlatches, illegal. So the systematic disruption of those cultural buffers, which does, really inform us as to why we have these health gaps with Indigenous people more often having these negative health outcomes that we see there. And so I think part of our work in public health now, first of all, is to recognize that actually the cultural identity is a positive determinant of health for Indigenous peoples, because often when it's included in determinants of health, there's kind of a negative slant to it. So that cultural identity and cultural connection is a positive determinant of health for Indigenous peoples. And then I think that we really need to spend some time reflecting on the ways that public health practice, our programs, our services, our ideologies may have actually contributed to disrupting that cultural connection. And I would just reflect, for example, on the ways that public health may interface with child welfare in the early days of a child's life with their family as one example of that. I think that it's important for us to reflect on what our role is in supporting the development or maintenance of strong cultural identities. And of course, if we are going to talk about our role in creating space or promoting strong cultural identity through our programs, do we have the right workforce to do that? Because that does really require Indigenous leadership. In the absence of an Indigenous public health workforce, I think we would run the risk of wading into dangers of cultural appropriation. So moving on to the next slide, which is the right to free, prior, and informed consent. So simply, it is the right for Indigenous peoples to be consulted and make decisions on any matter that might affect their rights, freely, without pressure, and with all the necessary information available to them, and before anything happens. Now, most of the time when this is raised, it's raised in the context of land or resource development, but certainly in its original intent and as it's written in the UN Declaration, it is on any matter that may affect their rights. And this certainly does include the right to the highest attainable standard of health. So in public health practice, this can be understood as the right of Indigenous people to be involved in identifying what community health priorities are. So, for example, where funding calls should go to meet those priorities, understanding the context of those health priorities, participating in program design and implementation. And what's really important as we hopefully are moving to more of these collective processes that include kind of the formal members of the public health system, as well as a diverse group of Indigenous people who are actually impacted or receiving services from that system, that we are deliberately putting all of the relevant knowledge on the table. So certainly the public health evidence and knowledge has to be shared in a way that is understandable to everybody relevant to the context, but also the local or relevant Indigenous evidence, knowledge, and science around that specific topic is also shared amongst everybody involved. If you look at some of the literature around Indigenous planning, one point that is made that is really key is that it is the Indigenous people around that table who have the right to weigh that knowledge and evidence and decide which is the relevant knowledge and evidence to consider moving forward for the planning and development and implementation. Also, linking back to the right of self-determination, that when we are having this collective type of processes, that actually the decision-making power has to be redistributed to Indigenous peoples. Otherwise, we might be doing consultation, we might be doing engagement, but we are not doing self-determination and free, prior, and informed consent. Now, I do want to recognize that sometimes this does create tension. And one example that I'm going to use just really briefly is the example of safe sleep. Now, a lot of the public health evidence that is currently shared has to do with babies being put on their back to sleep, not co-sleeping, not swaddling, because, the name of the example, safe sleep practices, going to sleep for babies. So a lot of the current information that comes out from public health is those things. Baby sleeps alone, but in the room. Baby is in a crib or box without loose blankets or warmers. but babies not swaddled because that might run the risk of overheating them, and some of the evidence around overheating and infant mortality or sudden infant death. And so actually in the hospitals around here, there's often no swaddling signs on the bassinets in the hospital. On the flip side, there are long traditions over thousands of years of babies being swaddled in moss bags, artica noggins, or cradle boards. And with the resurgence of Indigenous teachings around pregnancy and birth and infant development, actually a rise in these practices again, at least anecdotally being witnessed. And I have seen around tables the way that this creates tension. And in fact, I had heard at one point that our previous medical examiner had put a ton of pressure on some of the First Nations women around here who work with moms and babies around, you need to do something because your babies are dying at higher rates. So people really having a lot of weight put on them to intervene in the higher infant mortality rates. And that is kind of how it's often positioned. If you swaddle your baby is going to die. So you can only do this behavior. And if you do anything outside of this behavior, you're a bad mom because you're putting your baby at risk. And I'm wondering if we followed the example I gave before, the process that I started to talk about before, where we did put the public health evidence and knowledge around safe sleep and current recommendations around that from that evidence base, and also had Indigenous kukums or grandmothers and aunties doing teachings to young families about moss bags or cradle boards or baby swings. And actually, rather than assuming Indigenous moms were bad moms, trusted those moms to make the best decision for their babies with all of that relevant information. That would be another way that we could respect both free prior consent and also self-determination. The other thing that I would just point out was that if we created a society that had equal opportunity to be healthy, where moms, babies, and young families actually had adequate food security, adequate housing, and adequate income for life, then we would more likely see those gaps in infant mortality decrease, more so than just these sleep practices. I'm going to go on to slide number 9, which is the protection from discrimination. And this is the right to work, live, play, grow in settings that are free of racism. And I just wanted to spend a minute going through this table and defining the multiple levels of racism. Microaggressions came up once before. These are the daily commonplace verbal and non-verbal attacks on Indigenous people's dignity. So it can be the eye rolling in the meeting. If someone tries to raise an issue, it can be telling them that they're too sensitive or their feelings aren't valid or that's not what the person meant. Sometimes I talk about this as like osteoarthritis, right? So it's the wear and tear over a long time that causes that chronic stress and the burden, as opposed to like the one single dramatic incident. The one single dramatic incident is usually more along the lines of the personally mediated racism. And this has to do with the discriminatory action by members of a dominant group against Indigenous people or people of color. One example I'll give that I just heard about yesterday, which is not to pick on public health nurses. It just happens to be a nursing example. And it wasn't a public health nurse. It was a nurse in the hospital. It was of a client of a public health nurse who was seeing a young Indigenous mom. And in the hospital, she had declared her intent to breastfeed, of course, expecting that everybody would be supportive of her in that. Some of the Winnipeg context for people who don't know is all of the lactation consultant funding got cut. And so the nurses are now expected to do all of the breastfeeding support. And rather than getting breastfeeding support when she was having trouble, she was given a bottle to feed the baby. And when she said to their nurse, "Oh, no, I want some help. I wanted to breastfeed," the nurse said to her, "Well, don't all of you people use bottles?" So that is an example of this type of personally mediated racism. Institutional racism is the differential access to the goods, services, and opportunities of society by race. I've mentioned income and poverty a few times, but even the fact that Indigenous peoples are clustered in the lowest income gradient with much less Indigenous people in the top 3 income gradients are an example of how institutional racism is enacted or is embodied, right? Because if we all had fair access to income, we would expect that Indigenous people would be 20% in the first gradient, 20% in the second, and evenly distributed along. Institutional racism also doesn't need to have an individual identifiable perpetrator. Most of the time it's evolutionary and it's embedded in structures. So another example in healthcare can be what's covered by non-insured health benefits by the federal government for First Nations people compared to what's on the provincial formulary. Epistemic racism, I've already talked about before. So that can be in terms of requiring Indigenous knowledge to be validated through Western knowledge mechanisms like research before we would consider it equally valid in terms of its benefits to Indigenous people's health. It's sometimes also the use of Western science to prove racial inferiority. So when we set up our studies, and at the end of the day, we say the difference in this outcome is really only due to Indigenous status, rather than further unpacking what it is about being Indigenous and the interface between indigeneity and the settler state that contributes to those different outcomes. And the last one I'll just really briefly mention is internalized racism, which is when oppressed individuals or communities accept and begin to believe the discourses of their inferiority. And oftentimes, this can present as mental health stress or in no longer standing up for yourself when you're experiencing racism in any setting because you believe that that is how you should be treated. Now, in terms of applying this to public health, I think as far as institutional racism goes, we certainly do have an advocacy role, which is one of the core functions of public health. So I think how we frame our analysis and specifically look for differential impact, whether that's through things like equity-focused health impact assessments or other tools, that becomes really important. I think that we do need to be vigilant and have a way to monitor and remediate when we do have members of our staff who do display racial microaggressions, or we have a client who's received services from us or had an interaction that was experienced as racism. We certainly need to be able to respond to that. But I think a big one is addressing that epistemic racism and really making space for us to honor Indigenous knowledge and all of the other rights that I've talked about today in the work of public health. Now, this is the last slide I'm going to do before I start opening it up for any questions. So if you are wanting to send questions in through the chat box, now would be a good time to start typing them in there. Otherwise, we'll go to some of the other ones. Now, the one point that I wanted to make with this, particularly in relation to a discussion of UNDRIP, is that we cannot both maintain systemic or institutional racism and say we're doing the work of reconciliation. Because reconciliation at its very heart is creating a relationship between Indigenous people and settlers or the settler state of Canada that is mutually respectful and is rights-based. So these 8 white identities, I would actually encourage you not to think about individual people, but actions that operate to uphold systems of racism or systems that are founded within those ideologies of white supremacy and colonization. So when we undertake actions that uphold this current system, then we cannot also be doing the work of reconciliation. At heart, reconciliation is about full respect for Indigenous rights and the redistribution of power in the relationship. At this point, I'm going to take any questions.